Hi, everyone, and welcome to a live chat with Nurse Linda. Today's topic is skincare. Linda Schultz is a leader and provider of rehabilitation nursing for over 30 years and a friend of the Christopher and Dana Reeve Foundation for close to 2 decades. Now I'm going to turn it over to Linda. Hi, Linda.
Hi, and thank you. Welcome, everyone. It's nice to be with you. First, I must offer my apologies as I was unable to make the webinar last week. And so we had to delay. So I hope that did not interfere with your schedules. Unfortunately, my mother had become very ill. And so she's fine now. She had treatment and she's doing real well, but it was touch and go. And so I just didn't feel like I could actively participate as much as I would like to in the webinar because it was a very bad day in our family. But anyway, everything worked out great, and you just never know how that stuff is going to go sometimes. So fortunately, it worked out in a favorable way. But I thank you for coming today. Our focus has been on skincare this month, and we'll continue with that in the webinar. But you're welcome to ask any questions that you want. And you'll see we have some different questions in the queue already. So anyway, talking about skincare, let's just talk about it in general a little bit. Sometimes people kind of tend to ignore their things that they need to do when they have decreased mobility. And one of those things that they have to do, that you have to do or have done for you, is to have that pressure release. So if you think of, I'll just use my finger because that's easy to see on camera, but wherever there's a bone that sticks up close to your skin is where pressure can be applied from the inside of your body to the outside through that skin. And so, there's a bone at the end of your finger, but there's some nice padding there. So that's not quite such a pressure area, but it can be if you were constantly putting pressure on the tip of that. Even though there's some padding there, padding doesn't always help. Sometimes people will say, oh, I don't need to do pressure releases because I've got a lot of padding on my rear end. In other words, a lot of little extra fat there. But if you're too thin, or if you carry too much weight in your body, both of those are trouble points, because that fat tends to, when you put pressure on it, fat tends to just collapse, causing more pressure. So that's a problem. And if you don't have enough muscle mass or padding between your bones and your skins, that causes pressure in other ways. So a good balance is good. The more you can build up your muscles tend to be more cushiony. Fat tends to collapse like pillows or craft foam. Sometimes, people will put a pillow in their wheelchair because they think that's some cushiony padding, but that just tends to collapse, so it doesn't spread the pressure out. So you have these pressure points all over your body. Your knuckle is one. These are all pressure points. Your knuckles and your joints in your fingers. Sometimes we see pressure areas develop on these spots because of that proximity of the bone close to the skin. Somebody wears a splint and they have a strap that goes over that area. Maybe it's too tight, or maybe they have some spasms and that rubs those knuckles up against that. So sometimes people get pressure injuries there. On the wrist, you'll find there's a little bone on the inside, but there's a bigger one out here on the outside of the wrist. It's funny how people are, though. Everybody's anatomy is, it's the same, but it's different. Just like every spinal cord injury or every neurological disease, it's the same, but they're all different. So, we all have a little bone here on our wrist. And it's kind of funny because on this side of my wrist, it's kind of flat. It's there, it's present. There's a bone that definitely sticks up there, but it's kind of flat. But on this side of my wrist, there's a real pointy bone there. So if I feel them, I can feel that they're shaped completely different. So, you just have to be cautious with all of your bones. Elbows, shoulder blades, the bone at the back of your skull there. Sometimes the cartilage in your ears. If you're laying on your side, you can have trouble. You can go down through your body and you can find bones that stick out on your knees, on your heel. The areas that we're particularly sensitive about monitoring, we monitor all the bones and the bony prominences. But one of the areas that we're particularly monitor is the bones where you sit at the end of the pelvis. So they're kind of like it when you're sitting, they're like right in the middle of each cheek of your rear end. And so there's a lot of fat there in the bottom. That fat doesn't disperse, it flattens when you have pressure. And when you're sitting, you have the weight of your whole body going through those two bones. So the upper part of your whole body weight is resting on those two bones. Now, so it certainly disperses out, that weight disperses out through the top of the back of your thighs and through your bottom. Also, another sitting area in particular to look out for is right at the top of the gluteal fold, right at the top of where your bottom is. And that's the sacrum. That's another spot that takes a lot of pressure when you're sitting. But any place can be your hip bones at the top of your hips, where your hips meet your body, your torso. There's some bones that stick out there. If your wheelchair is not, if the seating area is not wide enough, they can rub up against the side of the chair. So there's a wonderful skincare booklet that's available through the Christopher and Dana Reeve Foundation. And they go through the whole body, and there's a circle where there are all these bony prominences that stick out. There's some that people don't think about, like the one I mentioned on the back of the skull. Every single vertebrae or your shoulder blades, all those can get pressure areas. Your feet have a lot of bones, as your hands have a lot of bones in them that have bony prominences. Now you'll notice, like here in the back of my hand, there are bones that go in there, but they're long bones and they don't have any parts that stick up in particular like my knuckles do. It's kind of really smooth right along in there. So you have less chance of skin breakdown there. But if you had a strap or something that's going across the back of your hand, just across, you can get a pressure injury from there. Once you see a change in your pigmentation, you'll know that you have a pressure injury that's developing. And we used to call them pressure sores. They used to call them ulcers, bed sores. Those are all names for the same thing. It's just as time goes by, researchers and practitioners tend to call things by different names. We call them pressure injuries now because it is an injury that happens to your body. And the idea is that if we call it pressure injury, it takes away some of the stigma that you did something to cause that. Sometimes we sit too long and don't do pressure releases, or we have something that's too tight. And yes, that does cause the pressure injury, but sometimes they happen due to nutritional factors. Maybe you're dehydrated for a while, maybe you're not getting the right nutrition. So there's so many causes for these that we can't say really, well, you didn't do what you were supposed to be doing. There are just so many causes that can help these. Sometimes people say, I did everything. I did my pressure releases. I've eaten a healthy diet. I've done this, I've done that. And still, for some unknown reason, they form. So don't really feel embarrassed if you have a pigmentation change on your skin that you need to have a healthcare professional examine to see if there needs to be any kind of treatment or something done to that, because there are thousands of reasons why a pressure injury can start. So don't be embarrassed and think, well, I'm not going to go. I'm embarrassed. They're going to yell at me or anything like that. Just go and have it checked out, because you know that you have not really caused this. These happen, unfortunately. And for some people, they never have one. They for some odd reason they don't. For other people, they're more prone to them. And why that happens, nobody knows. But if you have a change in pigmentation, especially over a bony area, bony prominence, for people who have darkly pigmented skin, the change in pigmentation might look purple. It might look what sometimes is called ashy. So it might look just a different shade than your normal pigmentation. For lightly pigmented people, the area will look pink or red, or it can look purple. If you have one of these spots, these changes in pigmentation spots, then that's a stage 1, a pressure injury. Stay off of it. Don't put any pressure on it. Now people will say, well, I have to get up, I have to go to work, I have to get up and brush my teeth. No, stay off the area because you don't want it to advance any further. If it's just a spot on your skin, well, we see the spot, that we know there's an injury, but inside the body where we can't see, there's a lot more injury. Pressure injuries are kind of like icebergs. You see a little bit of the iceberg on the top of the water, but the iceberg is much larger inside the water. So they're kind of like where you can't see, that's where the real trouble has come. They usually start, people think because they see the spot that it started on the skin, but it hasn't started within the skin, it started within the body from that pressure just pushed on there for too long. A stage 2 is when that area has opened. It might look like a blister. The skin might have come off of it. Again, you can get those healed up by staying off of them. People will say, well, I need to get up and brush my teeth, or I need to get up and sit up for just this long. But the minute you sit up, if you've not been putting any pressure on that area, or if you roll on that side, you've negated all that because you've applied the pressure back again. So the reason why the pigment changes is because the capillaries, the blood vessels, are getting compressed. They can't let the blood through. When the blood gets not through long enough, you get this breakdown, and eventually you can end up with a stage 3, which is an opening through the surface of the skin into lower tissue of the skin. And then stage 4 is very deep into the skin and possibly as deep as down to the bone itself. And then there's also these unstageable ones. So sometimes you get like a scab or a crust over the open area, and we can't see in there, so we don't know what stage it is. So for 2, there's some treatments where maybe some medicated ointment or some dressings might be put over that area, because you have an open area in your skin then, so bacteria can get in there. Then stage 3, there might again need some medication. You might need oral antibiotics if there's an infection. Sometimes the infection's so bad you need IV antibiotics. That might need to be cleaned out at 3 or 4. There might need to be packing put in, because your skin is so wonderful that the minute that there's any kind of opening in it, it will start healing, and it heals across to close the area so bacteria can't get in there. Now that's one of the marvels of the body, that does work that way. However, if that pressure injury closes on the surface, but it hasn't healed on the inside, you can get like a festering sore in there. So if the skin closes on the outside before it's healed from the bed of the ulcer, from the inside at its lowest point, then it can have bacteria contained and closed up in there. It still is festering in there. So you want to keep the skin open, and that's when we do the packing and that sort of thing to keep the outer surface open, so that inside, so you need them to heal from the bottom up as opposed to closing over the skin. So those are just some fundamentals, but the way that you avoid these is to do your pressure releases. So if you have to turn in bed at night. I mean, sometimes people say, well, I have a bed surface, or can I get a better bed surface? All those are helpful. They help disperse the pressure so that it's not just one point, but that the pressure spread out a little bit. But the reality is that there is not a piece of equipment that can eliminate pressure completely. It just does not yet exist. I don't know when it's coming. I don't know. I'm sure people are working on it, but there's just not anything that will eliminate the pressure. You still have to turn. If you're in bed, you have to do your pressure releases if you're sitting. So pushing up in your wheelchair and holding your body up off the surface that you're sitting for a few seconds, 20 seconds, 30 seconds. It's a long time when you're trying to hold up your body. If you don't have that kind of power, do this with somebody who's with you at first, because sometimes people who have trouble with sensations also have trouble with knowing where their body is in space. So work with somebody and do your tilts. So tilt this way, releasing pressure on this side where you're sitting, tilt this way. Some people will be able to tilt forward. That is really dangerous because once you get that body in motion, you can just topple right out. So be careful about those things. And you really need to do these every 10 to 15 minutes. That is like every time you're turning around, you feel like you're doing it. So it really has to become a habit. Some people will watch the clock. Some people will get a watch that beeps every 10 minutes so that they know to do that. After a while, you kind of get into the habit of doing it. And it becomes second nature. It's a good exercise to strengthen your arms if you have that function. Tilting in space in your power chair is certainly helpful. And you know, that's kind of easy because you just have to move the button or have somebody move the button, the gizmo that tilts your chair for you. Sometimes what I tell people to do is if you work in a busy office, listen for every time the phone rings. If you hear the phone ringing, you might do it a little bit more often, but more never hurts. If you're watching television in the evening time, it's real easy to keep track because every time a commercial comes on, it's going to be about 10 minutes or less. So every time a commercial comes on, that's time to move your body. For all of us, if we're watching TV in the evening time, if you have movement issues or not, at commercial, stand up, sit down, move around. It's good to keep your body in motion. You know, sitting is the new way that we're harming our bodies because we all sit too much and don't move enough. So even if we don't have movement issues, move. If you do have movement issues, still move. Just, you know, you just do it differently. So that's just kind of a kickoff to this. You know, it's something that people grow weary of hearing about, but it's something that really needs to be done. So such as will a cushion such as a Rojo or filled cushion work to reduce the incidence of pressure. It does help disperse the pressure. Rojos are very good for dispersing the pressure, but you still have to do the wheelchair push-ups because there is nothing that eliminates pressure. So unfortunately, that's where we stand. But let's answer some questions now because we'll get a little bit more into it. And so the first question is it's a little off the topic of skin, but that's okay because this is open. We just answer, we put a topic out there, but you can ask any question you want. For me, unfortunately, this question is in Spanish, and I'm afraid to say that my high school Spanish is failing me, but I think I get the gist of the question. So Anna or Ana, whichever pronunciation you use, I apologize, but I think I've got the gist of the question. It's about a person who has a C3, C4 injury, and they require a respirator for ventilation, which is not unusual at that level of injury. So they want to know what alternatives there are, and they're asking about a diaphragmatic pacemaker, I do believe. So at C4, that used to be the cutoff for those who required ventilation and those who didn't. It no longer is. A lot of people at C4 can learn to breathe on their own, either for part of the day, maybe they use the ventilator only at night. Some people get off of it completely. Some people will change to a CPAP ventilator. There are also different kinds of ventilators. So most of the time we see them where the ventilator is hooked up to a trach. There are different kinds of connectors. So you can have something that is applied under your nose, an external thing that forces air in and out. So there's all kinds of alternatives. But at C4, usually I see it more from specialty spinal cord injury hospitals. People can learn to get off the ventilator. Now, C4 is not a C4 injury the world around. Not everyone can. A lot of people can if they have the specialized training. I don't know of any places that are it's not like every rehab center does this. You might find a facility where it's not a rehab center for spinal cord injury in particular, but it's a rehab center and they have a connection with a pulmonologist that has been familiar with this, maybe has done it someplace else. So, you know, always ask, because you never know how people are connected. Maybe they have a buddy from school that does this and they can work together. And you just always ask. So you never know. Now, you know, you can have a C4 injury and your buddy next to you can have a C4 injury. So you think you have the same injury, but no two bodies are alike and no two injuries are alike. So what your buddy's doing may not be able what you can do, and maybe what you're doing may not be what your buddy can do. So you always have to, you know, think about your own self and your own healthcare needs. It's good to look around and see what other people are doing. But think about that. Now at C3, that's kind of very iffy if you can use, if you can get off the ventilator without any assistance. That's really where the diaphragmatic pacemaker came in. Now, I will tell you, and you know, this caused me a very happy memory, because when I started out as a newbie nurse, 21 years old, and there was a patient there who had diaphragmatic pacemakers. He had two, one on each side, and an external control, and a wire that went in through the skin and attached to the diaphragm. And so I'm 21 years old, and here's this patient. He's breathing with these pacemakers, and I recall him. He was lovely, and his wife was so lovely. I was just in love with him. But anyway, kind of funny, because at that time, I remember at age 21, he was kind of old. And now I'm thinking, gosh, he was in his 60s. And I'm thinking, not so old anymore. Just kind of one of those funny things that, you know, it's like, now I recall that. But anyway, he had these. Now, it used to be very difficult to put in diaphragmatic pacemakers. It was with the open surgery, which is like what he had. And that's the way you put them in years gone by. Now there's this Dr. Onder in Cleveland at the FES Center who puts them in using minimally invasive surgery. And he has put this out, and I think I haven't checked up on it for a while, but the last time I checked on it, they were getting ready to go public, so that you would be able to sell them all across the United States, and there, you know, different people could put them in. So it was in a research mode, and he either is very close to making them available, or well, around the world, or it's either very close or it's happened. So I'm not sure where we stand on that. But if you go to the Cleveland FES Center, or if you go to the Reeve Paralysis Foundation, there's more information about that and resources that you can check into that. So now that they do it with minimally invasive techniques, we'll be seeing a lot more of these coming out, because it's not so risky as that big general surgery. So could this help this person with C3-4 injury? Yes, of course it could. The difficulty is going to be to find somebody who can put it in, and of course, you know, your payer source. But it would be so much easier to get rid of that ventilator, maybe, you know, even to be able to get rid of the trach. Sometimes you can, sometimes you can't, but that of course is the goal. So there's a lot of hope there, so be sure and check into that. The next question is for somebody who says, how can I heal my bruises? Now, bruise is different from a pressure injury. So I'm just going to say, so if you bump up against something, you know, if I hit my arm on the side of my desk, I might get a bruise here, which is some broken blood vessels from an external source. But a pressure injury comes from the inside. So a bruise will go away on its own. It's some broken blood vessels, but they're still getting the blood system that they need. So it will heal up and it will go away on its own. You do not want to rub it, because that just further breaks down those already broken blood vessels. So just leave it alone. A bruise will just go away. If you have, if you're calling your bruise a pressure injury bruise, it's really a pressure injury. It's not really a bruise like that. It's something that's coming from the inside. So the only way, if you have the stage 1, so the skin is not broken open, the only way to heal that is to keep pressure off of it, completely 100% off of it. Now, people don't like it if they have to lay in bed for a day or even a week until their pressure stage 1 injury resolves. But I'll tell you, it's much easier to be in bed for a week than if it continues to break down, if it gets so bad that you have to be off of it for months, or if you have to have surgery to close it. Then usually you have to be off of that area, and they sometimes make you sign a contract. If you have surgery, you have to be off of that area sometimes for as little as 6 months. And I say as little as 6 months because it can be for 9 months or a year that you have to stay off that surgical area. Now, once you've had a pressure injury, you have a scar. Whenever you get an injury to your skin, you get a scar. So once you have that scar tissue is not elastic. It doesn't stretch like, whoo, look at that skin stretching. It does not stretch. And so it remains rigid. So it's always at risk of breaking down again more severely. So stay off of it until that red area or purple area or whatever over that bony prominence has happened. That certainly, will staying off a few days or a week or two is a lot better than the alternative if you keep putting pressure on it. That's also a question, is there anything I can put on my power chair to prevent damage to walls, corners in my home? You can get some of that foam tubing at the hardware store and put some padding on there. If you think about childproofing your home, where people will put like foam or different pieces of tubing that insulated tubing that they kind of split in half, and then they just like put around the edges of things, put that around the edge of your wheelchair, and that will certainly help, because yes, sometimes you have to make really tight turns in your personal home. They're not designed for the width of a wheelchair or power chair. So putting some padding around those areas will certainly help your house walls and that sort of thing. They also have some pain when they're sitting in their rear end. Now, the pain can be from, if you have pressure injuries, that can certainly cause pain. If you have pain sensation, if you don't have pain sensation, it can trigger autonomic dysreflexia. So, that complete release from the autonomic nervous system. So you can get a pounding headache. Not everyone does. You can get blurred vision. You can get goosebumps. You can have redness above the level of your injury. Your blood pressure shoots way up. So sometimes people who have pressure injuries, they are painful, but they don't feel that pain. So that's why your body doesn't alert you to move, because when you feel a little uncomfortable, we're always twisting and turning. And so if you don't feel that, then you tend not to do that. So it could be from your pressure injury, or it could be neuropathic pain. Sometimes people who have pain and like in the rear end or something, if it's neuropathic pain, it's a good news story and a bad news story. That means that the good news is that something is being transmitted, some message is being transmitted through that nerve where the pain is occurring. So you think, oh, okay, so I've got some nerve function going on there. Good news. The bad news is it could be referred from another spot, could be an incomplete message. It could be neuropathic pain where the area is just trying to get a message up to the brain to move or to do something. It's a kind of pain that just is, it's nerve pain. And so there's medications and treatments for that. So you'll need to find out if it's because of pressure injury or if it's because of nerve pain, because the treatments would be different. So I think there may be that they're going in the direction of pressure injury because they just got a new power chair cushion, but they're still in pain. So you need to do those pressure releases. That might help the pain. If there are pressure injuries there, you need to stay off of it until those heal up. If it's neuropathic pain, then you're going to have to seek treatment for neuropathic pain, which can be medications, or it can be sometimes if In very rare cases, sometimes some numbing cream will help. Doing those pressure releases, maybe a cushion that has an alternating pressure so that, like this side is more pressure and this side is low pressure, and then it reverses back and forth. A Rojo cushion is always good because those little fingers of the Rojo cushion, if you've ever seen them, they have these big tubules that come up, so that the idea is that your bony prominence sinks in between those little tubules, because that's what takes some pressure off. But there is no pressure cushion, there is no bed overlay that eliminates it. You have to do the pressure releases. And that's why talking about skin is always so uncomfortable, because nobody wants to hear that answer, but that is the correct answer, I'm sorry to say. They're also looking for some kind of financial support, because they're needing things that just are not available usually through healthcare insurance, like a carrier for the power chair or hand controls. So sometimes people will do a fundraiser of some kind. You have to be careful about that, because that does play into your taxes and can affect, if you have Medicaid, it can affect your benefits. Another thing is, there are some organizations that will help you get money for that. If you know somebody in your community, if there's a religious organization that you can petition, the community organizations like the Elks, the Optimists, all those kind of philanthropic organizations. Sometimes women's clubs will help people raise money. If you just keep talking to people and asking them what kind of organizations they belong to, you might find somebody who belongs to an organization. You ask them for help, but that person's not really too interested, or maybe they're not high enough in the organization to be able to bring something like that forward. So that you'll see in the chat box, there's some grant resources. People who go to Voc Education can get equipment, because if they're trying to get back to work and they need a ramp or some adaptation for their car, that they need this equipment that's impeding them to get back to work, sometimes Voc Rehab can help with that. So there's a lot of places out there that can help. So just, keep looking around. There was that one in the chat box. And I also saw somebody in the chat box asked if neuropathic pain can appear as sciatica. And yes, it can appear, because it's the sciatic nerve. So neuropathic pain is pain that comes from the nerve. It's different than muscle pain, like if you pulled a muscle or you overstretched or you did something like that. It's a nerve that's not signaling correctly. And nerve pain is if you have nerve pain, like if you've ever had a sore tooth, that's nerve pain in your tooth. It's pretty darn painful. And it feels kind of almost like electricity. It can feel like numbness, tingling. It takes a variety of forms, but it's pretty severe. Sometimes Botox will sometimes help that kind of pain. So there's all different kinds of treatments for neuropathic pain, but yes, it can certainly appear as sciatica. Somebody wrote in and they are just questioning about stiffness. And yes, sometimes our bodies all become stiff. If we don't use our body, we become stiff. If you sit too long and then you get up and, people say, oh, I'm stiff, or I laid on this one side, on my side in the bed too long, and now I'm stiff from doing that. So when you're not using your body, your muscles become stiff. Within your muscle, there's a stretch reflex within every single muscle, and your muscles want to move. So my hands are going to want to move this direction. So, and they might move this direction, or it might move a different direction, but the muscles are always wanting to move. So if you do some very gentle range of motion, that can help relieve that stiffness for a certain amount of time. Now, what you don't want to do is do some real aggressive, because that's going to fatigue the muscles. You can do aggressive things for other kinds of problems, but if you have stiffness, just do it very gently, because you're trying to move those joints and you're trying to stretch out those muscles and, try to, if you can't do it on your own, have somebody do it for you where you can, the fingers are kind of nice because you can do all four at once. And then just very gently unfold those fingers. You can do them one at a time and just very gently move those fingers. And fingers also move around just a little tiny bit. So move them each way. Have somebody, or if you can, move each joint just as you go up in your body. So that really helps a lot with stiffness. Here's a lady who's 43 years old, and she has been a C7 for almost 11 years, and her goal is now to use the toilet in her bathroom. She's been sitting on the commode for the first time, and all she did was urinate, which was great. But she wants to be able to toilet on the toilet, which, yeah, because that's where we go to the toilet. So why not? You should. And a lot of people in the rehab setting don't really get educated about going on the toilet. But going on a toilet or a commode, you're sitting up. And so you get to take advantage of gravity, which helps bring the stool out of the body. So you can do it laying down in bed, using a bowel program, using digital stim. If you have to do it in bed, lay on your left side, because anatomically that helps you to be on your left side. But the best position is sitting. The most common position for bowel movements in the world is squatting, because that takes advantage of those abdominal muscles. But after spinal cord injury, you might not really have use of that. So she wants to do her bowel program on the commode. Okay, so here are some tips for getting that accomplished. One is to put the suppository in. Now, if you've been doing it in bed, you know about how long it takes until your suppository works. Sitting on the commode causes pressure. That round seat is causing pressure where you're sitting. So you don't want to sit there too awfully long, because you're going to, you got to relieve that pressure. And commode seats have some padding, but it's not as terrific a padding as your wheelchair cushion. It does do some pressure dispersing, but not really a whole lot. So you still have to do all your pressure releases. So you put the suppository in, learn about how long it takes before your suppository works, and then move to the commode. You might have to have your suppository and then do digital stimulation before you move to the commode. For people who have problems with their bowel program, there are two kinds of suppositories that most people use. One is the Ducalox, one is the Magic Bullet. The Ducalox has a vegetable coating on it. The Magic Bullet does not. It's really personal preference which one you prefer to use. Some people need the extra time. The Ducalox with the vegetable coating takes a little bit longer to melt. The Magic Bullet does not have that vegetable coating, so it tends to work more quickly. Now, some people will be like, okay, well, my suppository works, but I need some time to get to the commode. So the Ducalox works better for them. Whereas other people, it takes too long for that suppository to melt. So I go with the Magic Bullet. Now, neither one of these suppositories will melt unless the suppository is placed against the bowel wall. When you teach somebody how to do a bowel program, the first thing they say is not, oh, goody, I've been waiting to do this my whole life. The first thing they say is, wait, you want me to do what? That's usually, there's quite a hurdle to get over. But after you do it a few times, maybe a dozen, maybe 20, you start to become more accustomed to it. You also need to do, so you have to put that suppository up against the bowel wall where the heat of your body will melt the suppository. If you just push that suppository straight in, you could put it straight in the middle of stool. It's not warm enough in there. The suppository will not melt. You're waiting. Why isn't this working? You might need to remove some of the stool before you put the suppository in to empty your bowel. That can certainly help speed along a bowel program. The other thing you have to do is digital stimulation. You might have to do it once or twice, maybe a few more times, but once or twice should really be sufficient. Be sure your finger is well lubricated. Sometimes people put a little bit on the end of their finger, and that's not really getting to the whole length of your glove finger. So this is one time where you want to be generous with medical supplies. So use some lubrication so that you don't create hemorrhoids, or that you're sure that it's moist enough while you're doing that. Some people have trouble with suppositories and they're not getting enough results. They will switch over to one of these mini enemas. Now, we tell you avoid full enemas because they flush out your bowel, and your bowel gets used to that and it stops or slows in its working because it's just used to being flushed out. It's one of those sayings, use it or lose it. You want your bowel to function in a normal way. So suppository, or these mini enemas, they only work in the lower part of the bowel. They don't flush out the whole bowel. So there's Enemies and there's Theravac. You can try some of those. You can go online, contact the company. They'll send you some samples. Sometimes your payer will not pay because they're a little bit more expensive. Then you have to write a letter of medical necessity. But if you can say, well, gosh, it took me this long to do my bowel program with the suppository, and but with this mini enema that I got these samples, it only took me this long. Sometimes you can use that in your letter of medical necessity to request the more expensive mini enema, but it's worth the trial and effort. Now, know that whenever you request something like this through a letter of medical necessity through your healthcare provider, usually the person who sends it. Don't try doing it on your own, because unless you know the lingo, you can really cut yourself off of an opportunity. So talk to your healthcare provider. See if you can get an order, see if the payer will pay for that. When they send off the letter of medical necessity, you pretty much are going to be guaranteed to know that that's going to come back with a no. Now, maybe not, but more often than not, it comes back with a no. So no, you have to do this several times. The response will not go to your healthcare professional who sent the request. It goes to the owner of the policy. So if that is you, you'll get the response in the mail. You'll get a written response. And then you only have so many days to respond. So get that response letter to your healthcare provider as quickly as you can so that they have time to do the response. It may take 2, 3, it may take even more, but you can be successful with that. Just keep hacking away at it. So anyway, yes, going on the toilet, if you've been doing your bowel program in bed, it's just a matter of working out some of those fine issues of when you should get on the commode, doing the digital stimulation. That is a must. And then you will have success. If you have success in bed, you can have success on the commode. It's just a matter of learning when to transfer and, being able to work through all the necessary things that you need to do, but that will happen for you. So keep going with that. The next one is, this is a really good question. I read this before. This is a person who have you seen any research regarding the use of CPAP? So that's a continuous breathing area, like when you have sleep apnea, keeps your airways open, especially while you're sleeping. And so this person is 35 years post SCI, and they just started using the CPAP machine, which sleep apnea is. This is a person who has C5-6. So as time goes by, your muscles may get weaker in your throat and at that level of injury. And so sometimes people require a little extra breathing assistance. For most people, if you have a spinal cord injury or not, a little extra fat in your neck can make those airways kind of collapse while you're sleeping. That's why people snore and etc. So CPAP is a good thing, and it's easy to use. But this person has started with this, and since they've started with this CPAP, they've been noticing that they've been having some GI trouble. And so she talked to the GI doctor, and they're like, well, I don't know anything about that. And she talked to the CPAP doctor, and well, I don't know anything about that. So I took some time to do some research on this because this is a very interesting question. So this is what I found: next to nothing. So at first, I'm looking spinal cord injury, CPAP, GI. Nothing with spinal cord injury. But when I took out spinal cord injury and just in the general public, because you are general public too, spinal cord injury does not exclude you from general healthcare issues that just anybody could have. I did find one article where there was something about the possibility of the CPAP causing some GI distress because of the microbiome. So the general, we have some general healthy bacteria that's in our gut that helps us digest food. And there was some way that the CPAP machine was connecting with wiping out that that bacterial biome. So there is something to this. So you are really on the cutting edge of what's going on. Now, the GI system is separate from the respiratory system, but all our systems work together. So there is no answer that I could find to this question, but there is some connection here, but it's not well known. It's, one article does not scientific evidence make, but at least there's something. So be sure you're cleaning your CPAP machine very carefully, because if some bacteria could be, bacteria easily collects in a CPAP machine, and they have to be cleaned, and the tubing and everything has to be cleaned very carefully. So follow that very carefully, because maybe some bacteria is getting in through that CPAP, traveling around in your body, getting to the GI system, that's working on the natural flora that should be there. And now this is just Linda talking. This is not scientific proof. I'm just trying to puzzle this together in my mind. But there is something there. You're onto something here. So be sure your CPAP is extensively clean. Talk to your GI doctor. Probiotics are so popular. And we now know that you shouldn't take them on a chronic basis. You shouldn't take them just continuously. When they first came out, it was like, oh, take these because it adds healthy bacteria. They'll be so wonderful, but it was giving people too much healthy bacteria. And so the body was, they were getting it through the pill and not making it on their own. So this is what we want, is the body to do its own thing. But talk with your GI doctor about maybe taking some probiotics just for 1 month. They come in the boxes are 1 month, and see if that helps. I don't know that it will. I don't know that it won't. I certainly don't recommend doing this just for anybody. Always talk to your own healthcare professional, because there could be something else that's going on in your body that I don't know about. And I certainly don't know everything, but this was such an interesting question. I thought, I've never heard of this before. So of course I went into my search mode and my research mode, and I was just like, yeah, I've got to find out more about this. And so just find out about that. Maybe something is happening there, but whatever it is, you're the first person to know about it. So good for you, and thank you for alerting us. Please keep track of what's going on and let us know, because I would just love to know how this all turns out, because there is something going on here. I know sometimes when you think something's going on and you talk to doctors and they're like, no, no. And that is the correct answer, but you're onto something. And so I know when I get talking about something and to somebody who's like an expert in it, and I'm kind of piecing something together, well, sometimes I'm, off the mark. That happens. And sometimes it'll come out like years later, and it'll be like, aha, I knew that. So you know it. So you're on the right track there. So let us know how that's going. This other person writes in, I'm losing muscle mass in my legs due to spinal cord injury, and the nerves are no longer there. Well, that could be, or maybe not. So we need to know a little more information there. Do you have any suggestions on how to keep going with what I have? Now, they're doing well with their upper body and core, but they've developed some scoliosis from lack of muscle to hold the column in place. Yes, as I was saying, no two spinal cord injuries are alike, and a spinal cord injury within your body. I don't know what level the spinal cord injury is on this person, but sometimes when they do the assessment and they assign your level and they'll say you're at, I'll say T4. Okay, and that's the last level of functioning. That's how they assign the level of functioning. It's the last level of functioning where things are working as they should be. But sometimes people have what they call a zone of partial preservation, and there's some functioning on one side or the other, or maybe they have some functioning at like T5 then, but it's not what it should be doing, but there's some functioning. So that's a zone of partial preservation. Sometimes people will have a T4 injury on one side and maybe a T6 injury on the other side. So the T4 would be their level of injury, but the zone of partial, the ZPP, zone of partial preservation, goes down to T6. So these muscles over here down in between 4 and 6 are still working. So they tend to pull and you get the scoliosis. So that is not an uncommon thing, but you can still work with your body and do exercises on the other side to strengthen, to help bring that back in. So you need to get with a good physiatrist or a good therapist who has experience with spinal cord injury that can help you correct some of these issues. Now, for people who have upper motor neuron injury, they can electrically stimulate their nerves and muscles. People that have those lower level injuries in the lumbar and sacral area, they are areflexic. They don't stimulate, but there are still exercises and therapies that you can participate in to help improve yourself. And that muscle mass, if you can electrically stimulate, comes back very, very quickly. If you don't electrically stimulate because you have one of these lower level injuries, there are still things that you can do, exercises and treatments that you can do. It just won't be through the electrical stimulation. There are some implants if you have these lower levels injuries that can help create some functional movement in the lower body, but it's all up to that. It's all depends on your individual injury of what's going on. But they do have, for people who have these lower level injuries that don't stimulate, say, through the skin, but they can do implants directly on the nerve within your body. So if you think like a heart pacemaker, where you have that little pacemaker device that goes under the skin, they can put that and attach electrodes directly to those nerves and get that functioning going. Now, if it's been a very long time, sometimes the nerves do die away from the muscles. And so that can be a problem, but do your due diligence and check all of this out to see. Again, at that, I mentioned that Cleveland FES Center, and just coincidentally, because both of these questions apply, not because of any, there's plenty of places, spinal cord injury specialty centers that do these things. But the Cleveland FES Center is getting ready to come out with these implantable stimulators that go directly on a nerve, not necessarily in the spinal cord, like we're hearing a lot about the epidural studies. So it's a little bit different. But those could be helpful. They were going to release this separate from the diaphragmatic. They were going to release this implantable stimulator, but then the COVID came and everything got messed up in that COVID. So check into that again, and again, check the Reeve Foundation website about stimulation and implantable and external. It might not work for you if you have a lower level injury, but it will work if they're implanted, if you're up for that kind of thing. Not everybody is, and that's okay. So the next question is the importance of educating newly injured people about pressure injury if they're going to be in a wheelchair for the first time. Nobody told me back in 1985 that a serious pressure sore made it harder to prevent recurrence in the same spot. And that is, yes, like what we talked about, because scar tissue forms, and that's more fragile tissue. It doesn't stretch. It doesn't have that elasticity. It has no give. So if you get pressure in there, and yeah, things have improved since 1985, so good, but you know, that was kind of an unfortunate event for you. Devices available for people to try to manage, control bowel incontinence. And again, there are some implants that can help do that. They're making a lot of headway with external implants in bowel and bladder as well. So not external implants, they're not implants because they're external, but some electrical stimulation to the outside of the body that is helping with that sort of thing. So stay tuned with that. That is moving at a rapid pace, and we're going to see a lot more. They have some devices you can wear that will stimulate your bowel and bladder externally. And so they're kind of new and novel. You know, keep on track with that, because that is going to be very helpful. Somebody has dry skin. Yes, sometimes people who have spinal cord injury do not produce sweat below the level of their injury. And that is because the autonomic nervous system does that. You can get overheated very quickly because you don't sweat, don't get that tiny little beads of moisture. So use an emollient-based lotion on your skin to help that dry skin, because dry skin gets very flaky. You can get calluses on your heels and on your hands. So you need to keep your skin moist. When we drink fluid, any kind of water, we have a natural moisture to our skin. If you watch the TV commercials and all the facial things, it adds hydration. So that's what you need to do to your lower body. But an emollient lotion, it doesn't have to be the most expensive one. Just anything that is an emollient type of lotion will help hydrate your skin from the outside. Drinking fluids as much as you can, according to your bladder management plan, will help control fluid skin moisture from the inside of your body. So use an emollient, and that should help. So the next question is about urine output, and it varies despite having consumed excessive amount of liquids. So our bodies metabolize at different rates. It depends on if, you know, we're hot outside, we might be sweating more, we might be urinating less. Depending on what type of fluid you're drinking, water is the best because it does hydrate your body. If you're drinking sugar drinks, alcoholic drinks, caffeine, anything that will dehydrate, or caffeine tends to run right through you. Alcohol tends to run right through you. Sugary drinks will run right through you. So water is the best. So it depends on what you're drinking, and it just depends on how your body's metabolizing. At night, our bodies tend to slow down in metabolizing. And so you put out less at night, but in the morning you've stored all this urine, so you have a larger amount in the morning. So it's just a natural rhythm. It's never going to be the exact same as you go along. So, here's from Peter. Hi, Peter, because Peter is with us. But yes, sometimes this is a very good point. If you're not moving your legs or your arms, your extremities, edema can collect in those areas. And when you lay down at night and put your feet up, that edema tends to, then now your feet are level with your heart. So that edema will move up because it's easier for the heart to pump it out. So that edema will move out of your body. So sometimes individuals who do intermittent catheterization, we say, you know, get into bed, read a book, you know, do what you need to do, but have your feet up maybe about an hour ahead of time before you go to bed. Then your feet are up level with your heart. You could be sitting, but your heart's still then above your feet if you put your feet up. But it does help to put your feet up even then. But when you get your feet up higher than your heart, or if you put your legs up so they're a little bit higher than your heart, that edema is going to run off. So then wait about an hour before you do your final catheterization at night. So time that from your previous catheterizations, but so that you've had an hour of time with your feet elevated so that fluid can run off. You'll have a lot more fluid at that last catheterization. Then if you lay down and you wait to your next catheterization time, so say you get up at midnight and you have this large volume because all that fluid now has run out of your legs and perhaps your arms if you have trouble with that. So yes, thank you, Peter, for reminding me. That's another significant part. Some people, I know we're out of time, but there's one last question here about barrier cream. So hopefully you won't be incontinent, and that you have control over your bladder, that you've managed it either through catheterization or some other process. Maybe you have an indwelling catheter or a suprapubic catheter. So the goal is to never be incontinent or wet. So there's a thing called skin prep. If you're using an external catheter and then urine gets on the penis, so sometimes that can be an issue. But it sounds like a barrier cream to use nightly. It sounds like this person's looking for over large skin areas. They're talking, so they're planning on being wet. So hopefully, you want to get your bladder under control. Even if you can't control it yourself, you can manually control it with catheterization and that sort of thing. So using that skin prep or something with zinc can help with that. There is a cream that I know several people that use it for a variety of reasons. It's a lotion that is used for diaper rash. It's called butt paste, and that is literally the name of it, butt paste. And that is a very thick emollient cream that helps, especially if people are having problems with incontinency or kind of a leaky stool kind of thing. So with that, we are at the end. If I didn't get to your question, there's 3 or 4 more questions down here. So if I didn't get to them, please feel free to contact me. I am on the Christopher and Dana Reeve Paralysis Foundation site. It's the community. You can post your question there, or you can email it to me privately through the community. And then, if you find it too personal, it's always nice when people post publicly, because I always find that, if that's your question, it's everybody else's question too. So I thank you for joining me today, and I look forward to hearing from you next month, and have a great month. And otherwise, I'll see you on the community and on the blog. Thank you.